Hi everyone, my name is Elizabeth Bilbao and I chose to do my master's project on gastroesophageal reflux disease, otherwise known as GERD. In this PowerPoint, we will discuss the etiology, pathophysiology, and risk factors associated with the development of GERD, clinical assessments such as common symptoms and physical exam findings, and how to diagnose and treat this condition. We'll also touch on some alternative treatments available other than medications. GERD is defined as excessive retrograde movement of acid-containing gastric contents from the stomach into the lower esophagus. The primary contributing factor to the development of GERD is lower esophageal sphincter weakness, resulting in inability to maintain a barrier between the stomach contents and the esophagus. This can lead to inflammation and eventually dysplasia and malignancy if not managed properly. Risk factors for development of GERD include obesity, alcohol or excessive coffee consumption, tobacco use, anticholinergic drug use, and low fiber diet. The most common symptom of GERD is heartburn, along with chest pain and reflux. The symptoms are often worse after meals and when the patient assumes a recumbent position. The patient may also experience hypersalivation. Physical exam findings are rather limited and nonspecific. The patient may exhibit epigastric tenderness, oropharyngeal mucosa erythema, wheezing, and/or dental erosions. Diagnosis of GERD is often made clinically based on history and physical. Providers should consider diagnostic studies for patients who are refractory to medical therapy. 24-hour esophageal pH monitoring is considered the gold standard, but often upper GI endoscopy is performed, especially for patients with dysphagia and those with chronic GERD and high risk for development of the premalignant condition Barrett's esophagus, which is shown in the picture on the slide. Esophageal manometry is used to rule out motility disorders such as alkalasia or esophageal spasms. EKGs can be used to rule out cardiac pathologies that may be causing the patient's chest pain. As far as treatment goes, prior to initiation of medical therapy, it is recommended the patient make some lifestyle changes, such as weight loss, limitation of nighttime meals, elevation of the head of their bed, and avoiding chocolate, caffeine, and alcohol. Increase in fiber intake also limits GERD symptoms. New research suggests aloe vera supplementation may improve symptoms as well. Pharmacologic therapy focuses on acid suppression. First-line therapy for GERD includes histamine 2 receptor antagonists and proton pump inhibitors, such as ranitidine, Zantac, omeprazole, Prevacid, and Nexium. Although chronic PPI use is linked to several adverse effects, such as osteoporotic-related fractures, Clostridium difficile infection, pneumonia, vitamin B12 deficiency, kidney disease, and dementia. New research focuses on improving lower esophageal strength as an alternative to medical therapy. Magnetic sphincter augmentation and lower esophageal sphincter electrical stimulation are shown here in the graphics on the slide, which both focus on improving lower esophageal strength. These alternatives to mainstay medical therapy of GERD have proven to be an innovative approach to long-term management of GERD symptoms. Barrett's esophagus is the most serious complication of uncontrolled GERD, where the normal stratified squamous epithelial lining of the esophagus changes to metaplastic columnar epithelium. This condition is a precursor to esophageal adenocarcinoma, and there is a 7% risk of development and high mortality rate. Other complications include asthma, chronic laryngitis, laryngeal and tracheal stenosis, and dental erosions. Patient recognition of risk factors for development of GERD is key in the prevention of disease progression. Weight loss, specifically with dietary modification, can play a role in prevention of GERD symptoms. It is recommended that patients with Barrett's esophagus have routine evaluation with endoscopy every 3 to 5 years in order to monitor progression. And that concludes my presentation on GERD. Here are my references.